So today we're going to talk about the aortic valve, and we'll try to keep this more of a conversation than a lecture. I mean, I think it's important for you guys to understand how the aortic valve forms, what is the anatomy of the aortic valve, what's the pathology that we're going to see, and what's the physiology of the valve. So, you know, a lot of this stuff you guys see all the time and know all the time, but there's certain parts that you really don't see very much, like the anatomy, what I see as a surgeon, and how that's going to play into things such as structural heart interventions, how it makes a difference. So one of the first things to do is think about, you know, how the LV really functions. It's a lot different than the RV, right? The RV is almost like a tube. And the blood comes in at one end, it goes through the RV, it comes out at the other end, which makes a lot of sense if you want to try to pump blood. But the LV is different. It's this truncated cone. It's like you cut the top of it, put a membrane over it, punch two holes, slightly offset them, and now you have your inflow and your outflow. Physiologically, that's a horrible arrangement to have the blood come in one way and go back out the same way. So it means it has to take a 180-degree turn to go out. Now that's a whole separate issue when we start talking about the mitral valve and the vortex. And I just spent last week or the beginning of this week in Berlin talking to mitral valve companies about transcatheter mitral valves. And one of the issues we've always had as surgeons is as soon as I operate on your valve and replace it, I've destroyed that vortex, which is a problem. And we're talking about ways to try to recreate that with a transcatheter mitral valve. And I keep telling them the first thing we need to do is get a valve that works. Then we'll worry about the vortex. But it is important to think about that because it affects how we approach aortic valve disease. Another reason it's important to think about it is that the aortic and mitral valve are really in continuity with each other. As a surgeon, I see it all the time. I open the aortic valve and I look down there and I'm looking right down at the anterior leaf of the mitral valve. But anything that I do to the aortic valve will affect the function of the mitral valve. So if we put a surgical or a TAVR valve in there, it affects the function of the mitral annulus. If I put something in the mitral valve, it affects the function of the aortic valve. And these two valves typically work in concert. There's some, you guys have probably seen great MRI pictures watching these annulus open and close against each other in systole and diastole. And particularly when you're young, the amount of stretch you get for both your aortic and mitral valves is quite a lot. As you get older, you get to be an old guy like me, it gets to be a little more narrow. So these are just some anatomic dissections that I've done trying to show this. You know, this is the non-coronary cusp. You can see this is the anterior leaf of the mitral valve. You know, one of the things that we do to make the annulus bigger, get a valve in there, is called the Nix or a Menugian enlargement. When we cut the leaflet out, we cut down through there into the anterior leaflet and just split it right there and then put a big patch on there. And that's the reason we can cut down there. Now you can't cut too far down because you cut the anterior leaflet in half, that's a bad thing. But you can cut about halfway down there, and you can widen it, get a valve that's one or two sizes bigger. It's also why when you have things such as endocarditis, after a while it'll tend to affect both valves because they're just really sitting on top of each other, and they tend to be contiguous. The other things to bear in mind is that if you look at the anterior leaf of the mitral valve, when you get to the junction of the non and the right cusp, that's where the conduction tissue is. And everybody worries about it. Now, you guys don't see it, but we see it all the time. And my residents always look down there and say, oh, well, how do I know where the conduction tissue is? Well, the truth is that there's going to be a white triangle of fibrous tissue. The conduction tissue is never in the fibrous tissue. The conduction tissue is always down in muscle. So as long as you're in white meat of the heart, you're okay. If you get into the red meat of the heart, that's where the bad things can happen to you. Now, that's not too much of an issue for you guys, but it is an issue when we do TAVRs, because we try to line our TAVRs up with this virtual plane, and the conduction tissue is right there. So the lower you extend, the more risk there is of interfering with the conduction tissue. But you guys have done this with us, notice that about 10% of the time, just crossing the wire across the valve will cause a left bundle. These older patients, doesn't take much to do a left bundle. Now, if you come back at 1 month and study these people, well over half of the left bundles are gone. They just go away with time. So the aortic valve is this, has several areas you need to know about: the annulus, the leaflets, the sinuses, the sonotubular junction. We'll talk about all of them. When we talk about the root, we talk about the sonotubular junction down. The ascending is the sonotubular junction to the base of the innominate. The arch is obviously here. When we do T-bars, we talk about it differently. Zone 0, Zone 1, Zone 2, and Zone 3 based on that thing. So if you get into doing T-bars with us, we divide the arch up in a different way. Now, when we first started looking at this, Nick Piazza, who's in Germany at that time, he's now up in Canada. Nick did a lot of really good work in helping people to understand this. Because when you tell a surgeon, I want you to trace the aortic annulus, what does a surgeon trace for you? What color? Tell a surgeon, show me the annulus. What does a surgeon show you? What color? Well, there's only 4. You got a 25% chance.
Yellow.
Yellow. No. Yellow is where the ventricular muscle actually hits the aorta. So that's the bottom of the leaflet. The ventricular muscle actually goes up behind the leaflet, and the aorta actually starts about right there. That's one of the issues with mitral valve repairs. The ventricle actually goes up above there. So that's a plane that we don't use for anything but maybe aortic valve repair. So that's now you're down to 3. So you got a 1 in 3 chance of getting that. What's the next one, surgeon? Surgical aortic valve, annulus. Well, I'll give you a hint. This is a sinotubular junction, so it's not that. Now you're down to 50-50. Huh? What?
Green.
Wrong. So you almost did it. So no, for the surgeon, this is the annulus. The annulus is where the valve is. When we cut a valve out, this is what you end with, this red thing. So when I'm a surgeon, I sew to that red line. Now that's kind of exaggerated, but to a surgeon, that's the annulus. The annulus is where the leaflet touched the wall. If you trace it, it's a cornet. The green ring is a virtual ring you make by connecting up the bottom of all the leaflets. That's what we talk about when we talk about TAVR. To us, that's the annulus. But that's really not, it's a virtual plane. This is actually an anatomic plane because that's where the leaflets touch the aortic wall. Now the interesting thing about that, of course, is when I sew an aortic valve in there, they're fairly flat. What happens? I flatten out the aorta. I force the aorta to conform to my valve, which is better than having aortic stenosis or severe regurgitation, but again, it's not as good as maintaining the normal geometry and function of the aortic valve. And this is what the aortic valve looks like if you just look at a normal aortic valve. Now, your eyes have to be faster than mine. What you can see is this thing doesn't become round. It becomes kind of a elongated triangle. If you look at it from below, it looks like this. And in fact, if you look at normal aortic valves, you see how thin these things are. It's a miracle these things hold up for a lifetime. I mean, these things beat a lot of times, but they still hold up. The other thing that's interesting about the aortic valve is that this leaflet has to open and close a zillion times. And the properties of the leaflet are anisotropic. I mean, they're different in different ways. If you pull them radially, you can't stretch it, but you pull them out towards the center, radial, I guess, the stretches, pull them circumferentially, they don't stretch. And what you have is you have these elastic fibers that allow this to crumple up and then stretch out, and it actually stretches towards the center to make coaptation. We're going to ask Jeff questions now that he's here. And now one of the problems we had with early tissue valves is they'd take a pig valve and they'd mount it on a frame. When they mount it on the frame, they would fix it under pressure. And what happened? You took all these little corrugations and you ironed them out. So it no longer had this nice little elastic stuff that let it open and close, but it was rigid. And instead of having like a piece of elastic, it's like having a piece of cardboard. If you bend a piece of cardboard, what happens? It bends at one spot. And that one spot bent over and over and over and over again, those valves all failed. So we learned to fix them with no pressure to leave that. So, the aortic valve is pretty much perfect, right? What could possibly go wrong with the aortic valve? Well, first of all, there are some congenital things that can go on. You can be born with a bicuspid aortic valve. So how many different kinds of bicuspid aortic valves are there? When we say it's 1 to 2% of the population, we all just kind of throw around bicuspid valves. But when you think about bicuspid valves, the way we think about them as surgeons is we think about how many commissural posts there are. So if you have a tricuspid valve, how many posts are there? There's 3, right? Trileaflet, 3 posts. And the coronaries are typically 120 away from each other. Then you move down to 2-post valves. And 2-post valves can be one of 2 things. It can be 2 posts with 2 equal leaflets with coronaries 180 degrees apart. They're really true bicuspid valve. And that's about 7% of the valves we see. And most of those valves actually present with pathology fairly early. They either get stenosis or early on you have some regurgitation from leaflet prolapse. And those valves are really hard to treat with TAVR because they never open up normally. I mean, if you were God, Jeff's the last guy, if you're God, Jeff, and you're designing an aortic valve, how many leaflets do you put in and why? 3. Did you hear this last year?
I remember it.
You remember, that's good.
Because it's a very good point.
Yeah, it's an interesting point because if you're God, you want to open up all the way in systole and close all the way in diastole. And if we assume the opening's a circle, which it's not, but just assume it because that makes the math easier, what's the circumference of a circle? 2 pi r. And pi is 3.14, so that's like 6.28 times r. And if you have a trileaflet valve and you go from the edge to the center, what is that? It's R. And the center of the back, that's R. So each leaflet is 2R, so it's about 6R, and it's a little, the free edge is longer than R really. And so it would open up to about a circle, and it can come back together. What if you have a bicuspid valve? How far can that open up? R, 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 R. It can never open up. And in fact, that's why instead of opening up like a circle, or what we see really a triangle, it opens up as a fish mouth. Because that's all it can do. And that's important when we get to things like TAVR to realize that it's never going to open up to the annulus that you measure. Because the opening at the top of the cone is going to be smaller than the annulus. And that does affect how we do things. And then there's unicusp valves that just have a single post. And then there's quadracusp valve, 4 leaflets. And you have 4 leaflets in your aortic valve? Yes? No? Reardon's up here just talking crazy. So with a quadracusp valve, you actually have an extra leaflet, and most of those present with regurgitation. Most bicuspid valves present with stenosis. So what we see most often is what we call functional bicusp, which means that you have 2 posts and 1 fused raphe. And the most common is the left and the right being fused. Now these people didn't fuse as they grew up. They've always been fused. So they're really bicuspid. They're congenital bicuspid valves, but they're a little different than the true 2-post, 180-degree corner bicuspid valves. But they're still different in the way that they open up, and they're a little bit different in their pathology. And most of these people also have an aortopathy associated with it, so we worry about an aortopathy that goes really all the way to the ligamentum arteriosum. You have to worry about the LV outflow tract all the way around. So, bicuspid valves, they almost always, if they're going to go bad when you're young, right? Get aortic stenosis when you're 40, 50, 60? Prime of life, 62? Is that right? So if you're 80 years old, if we take a population of 80-year-old people that come in with aortic stenosis to you as a cardiologist, what percentage of that population, 80 plus, is going to have a bicuspid valve? 20%. 20%. And they're functional bicuspid. But that's one of the things that's really shocked us, because when I was learning all this, we were taught that, basically the bicuspid were the 40s to 60s, and the rheumatics were the 30s to 50s, and the degeneratives were the 70s to dead. So, and then there's rheumatic. We really don't see much rheumatic disease except for people that come in. But if you travel the world, and I travel a lot, I was in India not too long ago at the All India Medical Institute, and it has a private side where they do a lot of coronary surgery and regular valve surgery, and it has a public side. On the public side, there's rooms that are 4 times this big, full of young people with rheumatic disease. We're not talking about 50 and 60-year-olds. We're talking about people that are 18, 20, and 21. And so there is a lot of rheumatic disease out there, and it still wreaks havoc. The problem is just disease control, which is really not antibiotics. It's really hygiene. I remember driving to the Taj Mahal when I was operating there, and I saw all these fields that looked like Texas rice fields that were like 100 yards by 300 yards with little dikes, and there was a little shed at the corner of each one. I asked my driver if that's where the farmer kept his tools, and he said, no, that's where the farmer lives. And it's hard for you to imagine growing up here that people live and their bathroom is their neighbor's field, and that's why things like rheumatic disease are going to be really hard to eradicate. But if I could take fellows over there, you could do mitral valvuloplasty every day until you couldn't stand. So, normal or abnormal? That's not a trick. Come on, guys. Does it look better than these other ones? Yeah, so normal, okay, well, we'll give you that one. So, look at this one down here, thickened rolled edges. What's wrong with that valve? Thickened, rolled, inflammatory looking edges. Rheumatic, yeah, I can't give you any more hints than that. And then you look at this one, and you have calcium inside the cusp. Trileaflet calcium inside the cusp. We used to call that senile calcific degeneration. As you get older, you hate the word senile, so now we just call it degenerative aortic valve stenosis. And how about this one? What's wrong with this one? Well, there's really 2 posts and a fused raphe. So that's a bicuspid valve. And bicuspid valves can have really, really heavy calcification. In fact, we had a guy, I guess it was the week before last, that had a functional bicuspid, and we put an Edwards S3 in him, and we ruptured his aorta. And it's probably because there was a big piece of calcium and it pushed up and just tore his aorta, which was really a dramatic thing. He did fine, but it ruined everybody's afternoon. Now this is another picture of a valve, and see that yellow right there? That's the earliest formation of calcium deposits. And this always forms on the downstream side. So on the aortic valve, it's on the aortic side. On the mitral valve, it forms on the ventricular side. That's why when I'm doing aortic valve replacement and I'm taking calcium off, there's often this big bar of calcium that's right over the anterior mitral leaflet. I just peel it off. It just comes right off. It's really easy. You just take it and you poke it off. When we do TAVR, though, that's a problem because we're trying to seal around this piece of calcium. So, you guys know the normal values. I mean, normal valve is 3 to 4 square centimeters. It's kind of like the size of a quarter, something like that. And generally you have to get to less than 1.5 before you start seeing any gradient at all. But of course the key to that is it all depends on how big you are. And then the real key to the heart is what happens to it when you stress it. Loss says that wall stress equals pressure times radius divided by 2 times the wall thickness. And your heart always strives to decrease wall stress. Just like all of us, we all strive to decrease stress. When my fellows come in late, I get all stressed, and then I have to increase the wall thickness and decrease the radius. And so what can the heart do? Well, the heart could lower pressure. That's really probably not a good thing to do. I mean, I explain to people when I'm talking about aortic valve stenosis when they come in and we're sitting for TAVR. So it's like if you went in your backyard and turned your hose on and put your thumb over the hose. The more you cover it up, the more pressure builds up behind your thumb. There's 2 ways to decrease that pressure. What are the 2 ways you can decrease the pressure behind your thumb if you're holding it over the hose? What's one way? Flow? Yeah, and what's the other way?
Increase the...
Take your thumb off the hose. Yeah, it's simple. Take your thumb off the hose or turn down the flow. Taking the thumb off the hose is a pretty good deal. Turning down the flow, if that means your cardiac output, is not a really good deal. And people really understand that. They understand the concept of that because they've all turned on the hose and put their thumb on it. And they understand what the issue is. So what the heart tries to do is it tries to decrease the numbers on the top and increase the numbers on the bottom. Well, decreasing your pressure is not a good deal. And you can only decrease your radius so much. You really can't get much smaller. And so the only option it has is to thicken up. And when we talk about aortic stenosis and death, everybody thinks this is what kills you. And this is, by the way, is actually a true 2-post valve, as you can see it. This doesn't kill you. This is what kills you. Hypertrophy kills you, not your valve, your hypertrophy. Why does hypertrophy kill you? Because hypertrophy is different depending on when it happens. If you're a little baby and you have congenital aortic stenosis while you're developing inside mom, what happens is that you grow a bunch of new muscle cells and a bunch of new vessels to make your heart thicker. What happens once you're born? Once you're born, all you can do is build bigger muscle cells without extra vessels. So every muscle cell becomes relatively further away from a blood supply, along with getting fibrotic. And so hypertrophy is, of course, a compensatory mechanism, but it turns out in the adult to be a bad compensatory mechanism. It will eventually hurt you. So when you get aortic stenosis, you tend to do okay till you get symptoms, right? We all know that. I mean, somewhere in here I have the famous Ross-Brunwald slide that everybody needs to be able to quote that came out in 1968 that says, you do okay till you get symptoms and then you die. And you die at this rate if you have heart failure, 2 years. If you have syncope, you die at 3 years. If you have angina, you die at 5 years. And that's because a lot of the angina we see is really not severe AS, it's just coronary disease. So when we look at this, half the people with aortic stenosis that I see, and that you see, also have coronary disease. So those without coronary disease, if you don't have coronary disease, normal patients can really increase their coronary flow 6 to 8 times in response to demand. But the problem is once you get AS, your flow reserve drops down significantly. And the best predictor of angina is diastolic dysfunction. There's been all kinds of things looked at, but the best predictor of if you're going to have angina or not is going to be diastolic filling time. Well, syncope almost always occurs during exercise. Why? Because normally when you exercise, you get peripheral dilatation and you maintain your blood pressure by just upping your cardiac output. Yeah. The problem is that with aortic stenosis, you can't up your cardiac output, and you can actually not really go much further because you're increasing your flow, your gradient just is higher. You can't keep up with the demand, and you faint. And it could also be due to arrhythmia. You put people on stress test, they sometimes just go into VFib and they die. We always talk about stress testing aortic stenosis, and some people say you should never do it. It's not a never, but you should do it pretty carefully. mean, if somebody really has, you know they have severe aortic stenosis, they're asymptomatic, you're going to test them. Be sure you have somebody there with them to resuscitate them when they fall over dead. Congestive heart failure, systolic failure is due to increased afterload or decreased contractility, and diastolic failure, of course, is due to the thickening of the heart. And of course, the most common cause of death after a successful aortic valve replacement is what? Heart failure based on diastolic heart failure. What's the most common cause of death for asymptomatic aortic valve disease? Surgery. Surgery. Yeah, that's a famous Brunwald quote. Somebody sends somebody to surgery with asymptomatic disease, they're more likely to die of surgery. Now, this is a long time ago, and surgeons have gotten better. But the point is generally, you don't, certainly for stenotic lesions, you don't have to operate if people are asymptomatic. I mean, it's almost never. Now, there are other indicators that we can talk about. So this is the famous Ross-Brunwald quote, came out of circulation in 1968. You know, you do okay, you get symptoms, and you just fall off the cliff and you die. And in fact, you know, we always had assumed this, and we had always assumed that surgery would be better than medical therapy. The first time we proved it, of course, was in the PARTNER B trial. It's the first time that anything's ever been randomized against medical therapy for aortic stenosis. And you know, although it seems intrinsically obvious that a TAVR would be better, you know, the people were so sick, we weren't really completely convinced. There was some chance that medical therapy could beat TAVR. Remember, in the early days of TAVR, the mortality was 50%. 50% when it first started. It wasn't 50% 30 days, it was 50% 30 minutes. In the early TAVR cases, either you did wonderfully or you died. And it was just a disaster. And it took a while to work these problems out. Now it's become pretty routine, but it was really tough. The only thing that's really different now is we have the same curve, but people are living longer, so the curve comes out to here, and you get to your 70s and 80s, and these are the people we're seeing. We're seeing a curve like this now instead of this. I'd love to be treating everybody in their 60s, but that's not the patient population that's out there. You guys know all this. I personally, what's not on this is DVI, and one of the things I'm pushing for all the TAVRs is that we include DVI as a measure of aortic stenosis. I think it's much more accurate. So anything that's 0.25 or less, we'll call it severe aortic stenosis and move on. You guys are familiar with Bernoulli's principle, what happens to the gradient, how to calculate the valve area. Flow equals flow. Now, you know, you guys, they make you calculate this thing by hand for a while till you learn it, but now of course there's formulas that you just plug it in, and then you get to be my age, you forget it. Remember, the thing that we always talk about is that pressure is going to equal 4 times velocity squared. That's only true if the LVOT flow is equal to about 1. Once that assumption, and it usually is, but there are other reasons that this can go off. You can have liver failure and be in a high flow state. Other things that can go off, which if you move to low cardiac output, means the less than 1. That's why the Gorlin formula can screw you if you've got a low cardiac output. As a surgeon, the worst thing that can happen to you is one of you guys sent me a case. There's a little tiny old lady, and you say she's got terrible cardiac aortic stenosis, and I operate on her and I open it up, and number one, her root's just a tiny little thing, and you look at the valve and it looks pretty damn good. And you've been done in by the Gorlin formula at low flows. And now we're going to take a valve out that probably, if you measure it with simultaneous pressure tracing, has a pressure gradient of 24, 25, and you're going to put a little valve in and leave her with a pressure gradient of 18 or 19, and they don't do very well. And what happens is these people come out of the OR with an intra-aortic balloon pump and a lot of inotropes, and none of those are the problem. The problem is you never really got rid of the aortic stenosis. I'm not going to spend a lot of time talking about this. I mean, when I talk to my surgical colleagues, it makes some sense. You guys know much more about echo than me. You know, it's just a funny machine that makes sound waves, and I look at these things. Cath lab and echo. Most of this validation work was actually done here. You know, Bill Zogby, Mike Canonis really did all the early work validating cath lab and echoes, and it is very, very reliable. I'm big on hemodynamics. If you guys come in and do TAVRs with me, we'll spend a lot of time looking at the hemodynamics. The shape of the curves, when the curves start and stop, are all very important. So when we look at hemodynamics, we do simultaneous pressure tracing, and we see something like this. And typically, I'll ask whoever's with me, what do you see? So Rob, what do you see in this? If we're doing a TAVR, what would you want to tell me about that? We're doing a TAVR, and I said, Rob, look at the hemodynamics. Tell me what's important. What would you tell me?
The the gradient between the LV and the aorta?
If there's no gradient, I've screwed up to begin with. There should be one before I get there. I've tested these people, so no, I don't care about the gradient.
Okay.
I mean, I'm assuming that we've done a good echo here. We've tried, these are people that are coming in with a diagnosis of severe aortic stenosis. If I don't see it, yeah, I'm concerned. But you know what? There's a problem there, because that's not what I really care about. What do I really care about? Well, one of the problems with transcatheter. Now, when I sew a surgical valve in, does it leak very often? Of course, with surgeons say, no, I've never had a leak. I've heard about leaks. I saw other surgeons had a leak once. But how about TAVR valves? Do they leak? Yeah, they do leak some, right? And so one of the things you want to know from your hemodynamics is, did you get rid of the gradient? That's very easy. I don't care where it started. We see where it ends. And then how much leak do you have? How do you tell how much leak do you have from hemodynamics? How do you tell how much AI you have from your hemodynamics? Gradient's easy. The red line should now match this line, right? If this line comes right up like that, then we have no gradient.
Blood pressure,
Pulse pressure.
pulse pressure.
Pulse pressure?
Yes.
Difference between
What?
systolic and diastolic.
Not systolic and diastolic. How do you tell how much AI do you have? So if you have severe AI, what happens? I mean, really bad AI. What happens at the end of diastole? The end of diastole hits the top of the LV EDP, right? Really bad. This guy will collapse right down to LV EDP. So what you really want to know is, what's the difference between the end of diastole and the LV EDP? What affects this difference? Well, one thing we've always said, AI affects the difference. I mean, if it's a wide open valve, it just crashes down the LV EDP and you die. What else affects it? Well, if you have somebody that has AI, some acute AI, not bad enough to kill them, but acute AI, and you're trying to medically tide them over, heart rate. Because when you change your heart rate, if you increase your heart rate, does systole get longer or shorter?
It's longer compared to diastole.
Doesn't change at all.
Yeah.
But diastole gets shorter.
Yeah.
And so what happens is you're shortened diastole, there's less time to leak. And so if you have bad AI, you want our heart rate going up because they have less time to leak. And so if you do hemodynamics, you'll see this if you come in and do this with us, if you do, they have a rate of 50, these two lines could be right here. And then you pace them at 80 and all of a sudden they go apart. We didn't get rid of their AI, we just changed the heart rate. Now what else affects this? The compliance of the whole system. So if you're an old person and you have steel pipes and there's no compliance, and it just goes up and down, these are going to be very close together to begin with. So what we do is we look at this and we get a fix in our mind of what this looks like before we start and what the heart rate is. And then when we're done, we want to see two things. This gradient gone. Yeah, we'd like to see a gradient beforehand, Rob, because we actually had one case where we got in, there was no gradient. And basically they had sampled behind the mitral valve and it was really embarrassing here at this hospital. So we want to see no gradient, and we want to see that wherever this started, I'm at least that good or better. Now, if you had pretty bad AI to begin with, then it should be a lot better. But most of these people don't have a lot of AI, and as long as this gets further apart and not closer, your hemodynamics are okay. And so that's really a key concept, particularly when you do TAVRs. Obviously, in the OR, we don't really do that. It doesn't really matter. You guys, I'm not going to spend a lot of time on the instantaneous peak of echo versus peak-to-peak gradient versus mean gradients. I mean, you guys all understand these concepts. We all use them a little bit differently. There's two things that get you into TAVR trials. Instantaneous peak from echo. Generally, it's 4 meters or above. Now, when the early TAVR trials, it was greater than 4 meters, which was really horrible because you get a guy that was 4.01 and your echo lab would round it down to 4. And they wouldn't qualify. So you'd have to go back and put the decimal point in there. So now all the new trials, I've finally convinced them that less than or equal to 4 is really the right nomenclature, because greater than 4 was the way the AHA and ACC originally said. It's just kind of crazy. We really don't use peak to peak except for when we're doing our hemodynamics in the lab for our TAVRs, but it's not a really meaningful number to us. And so, if you have severe aortic stenosis, you have symptoms, it's a class 1 indication for surgery. And there's some other indications. If you're asymptomatic, we're going to be operating on you otherwise, we should do it anyway. You start to drop your ejection fraction less than 50, your heart's not keeping up with it, and you think it's the AS, not other reasons, then you ought to operate on these people. And we could spend a whole afternoon talking about low flow, low gradient, and how those things parse out, because that's actually a really very interesting thing. In fact, maybe we would. So let's just say somebody comes to you and they have an ejection fraction of 40, and they have a peak velocity of 3.2 and a mean gradient of 31, and they have symptoms of shortness of breath, but they also have COPD. What do you do with that patient?
Augment the stroke volume.
You do what?
Stress does augment stress.
Yeah, well, okay, so you do a stress echo, right? And so what can happen on a stress echo? Well, you can increase your stroke volume, and if you increase your stroke volume and you have aortic stenosis, what should happen? Your gradient should go up. And so what you look at that is if the gradient, if the valve area that you originally measured is 1 or less and stays 1 or less, and your gradient goes up, and you augment by 20, then you say, okay, you got real aortic stenosis, we're going to fix you. What if your aortic valve area stays low, you don't augment, and your gradient doesn't go up, but the area is still low and you're convinced it's aortic stenosis? Non-augmenting, low flow, low gradient. Should you treat them medically or should you operate on them? Well, you guys are going to be seeing these people. What happens to them? If you treat them medically, they die. They die just like everybody else with aortic stenosis. If you have symptomatic aortic stenosis, you die. If I operate on them, their mortality can go up to 30%. But if they survive their surgery, they do okay. But the insult to surgery for these people is huge because they can't augment. In fact, one of the interesting things is that TAVRs that don't have that initial insult seem to move them up the bar, and then their survival gets pretty good. How about if you have the same patient, and now you give them 20 mics of dobutamine, and their valve area is 1.4, and the gradient doesn't go up? What do you do with those? Why?
Well, again, it depends on the symptoms, but if that has gone up, that means the patient, it was just a low flow state.
Yeah, it's pseudo-aortic stenosis. Generally, it's somebody with a bad ventricle and they have stiff leaflets and they just can't open them up. How about if you had an EF of 60 and you have a gradient of 32 and a valve area of 0.8 and symptoms that you think are aortic stenosis? What do you do?
Patient still has it, depends on how much stroke volume they have.
Yeah, so how much stroke volume would worry you?
I think index is 35.
35, less than 35 cc's, and that's called paradoxical low flow. That's usually the little old lady with the really thick ventricle. They just can't fill up. They can't eject, and they need to be fixed too. What's the one thing you have to worry about if your surgeon fixes a lady like that and brings them out to the ICU and they start getting hypotensive? What do you want to do for them? Yeah, they're suiciding, and what you want to make sure is your intensive doesn't put them on inotropes because they'll go down the tubes. And so we've seen this with TAVRs where they go up to the floor and they start getting a little heart failure late at night, and the first thing is, oh well, they must need diuresis. And they give them some diuresis and they get a little worse. They send them down to the ICU, and the intensivist goes, oh, well, they need inotropic support. Next thing you know, they're down the tank. These people will need to be filled up and beta blocked. And we see this once every month or so where you put the valve in and it looks like there's still a gradient even though the valve looks good, but it tracks the ventricular curve for a while and then falls off at the end of systole. And it's LV outflow tract. What you need to do is tank them and fill them up. You can also confirm that by just basically pulling your catheter right below the valve and it goes away. But long term, they just need to be tanked up. Difference between acute and chronic. If we talk about aortic insufficiency, acute aortic insufficiency is really bad. Why? Because your heart can't accommodate to it. So, normally, just say that this is their normal heart. We're going to kick out 100 cc's. So we fill up to 100, we decrease to 50, 100 cc's goes forward, a good LV EDP. Now all of a sudden if we go acutely and we stretch the heart, we can only fill up to about 170. We go down to 50 because there's kind of a slightly increased ejection fraction. 60 goes forward, 60 comes back out of the 120. You've got a real problem. You've got half a cardiac output going forward. And if you don't do something to fix this, they're going to die, even though their ejection fraction looks great, 71%. So acute AI is bad, and acute AI is bad in these TAVR patients we see because they're not like a normal person. They already have a thick heart to begin with. They're even less compliant, which is one reason they don't tolerate this. So what happens with chronic AI? Well, I always tell people, it's just imagine that if you need one cardiac output going forward and half of it's falling back, the way the heart can accommodate that is to fill up to 2 cardiac outputs and kick it out, and half falls back and half goes forward. Now you're better again. The problem is Laplace's law. And imagine squeezing a baseball, squeezing a softball, and squeezing a volleyball. Right here, you've got a softball, and it's harder to squeeze. It takes more tension to generate the same pressure. And eventually what happens is you fill up and you can't come down because you're at it even bigger, and now you've got a volleyball. And once you get to the volleyball, then you've just got end-stage heart failure. And obviously what we want to do is stop it before then. So, when do you fix AI? Well, if it's severe and they have symptoms, you fix it. Symptoms is always the key to fix something. But a lot of the regurgitant lesions are asymptomatic, and so the other thing we do is we want to see, is the heart really keeping up with this? And we really judge on 2 things. We judge on the ejection fraction. We judge on the ejection fraction, and we judge on how far the heart can come down the end systolic volume. And I use the rule of 55, but I think a lot of us are thinking it ought to be moved to 50. So if your ejection fraction is below 55, your end systolic, can't come down to less than that, then you need to be fixed. So what are the rules for TAVR right now? What's the indication for TAVR? What does the AHA, ACC, and European guidelines say for TAVR? They said they're pretty much the same thing for aortic stenosis and insufficiency.
Just moderate to severe risk patients?
High risk.
Oh,
High risk or non-operative. What does it say?
As far as level of evidence?
No, about whether do they recommend it. You mean you get a class 1, a class 2, 2A, 2B, class 3.
I think it's 2A.
It's a 2A. Yeah, it's a reasonable alternative. And the real question over the next year or 2 is, now that we have continued randomized data where up to 5 years is at least as good as or superior to, should it really be a class 1? And I think that's going to be the next decision for these guys to make, is it going to be a class 1? For moderate right now, it's still not recommended because we just don't have the data. There's really a lot of non-randomized data out there that's pushing towards moderate. And in this country, we're kind of slowly going towards moderate. If you look at the mean STS for the partner randomized high-risk trial, it was like 10.4, for core valve it was 7.5. In the STS registry across the TVT registry across the board for commercial cases, it's 7.1, but for transfemoral ones right now, it's 5. The STS is down to 5. That's considered by STS alone intermediate risk. Partner 2A is closed. It should be presented at ACC this year, and I hope to close out CERTAVI somewhere in the next month or 2. So how about AI? What can we do for AI? Well, we can replace it. We can put a new valve in, or we can repair it. The interesting things about repair is that there's really a couple things. One is it's the root anatomy. When the root dilates, we can fix that pretty easily. So there are 3 things that can dilate in the root: the annulus, the sinotubular junction, and the sinuses. What causes AI out of those 3? If you dilate the sinotubular junction, can you get AI? No? No. Okay, in the Jeff world, no. Okay. How about the annulus? If you dilate the annulus, can you get AI? Okay, everybody agrees with that. How about the sinus of Valsalva? If it dilates, can you get AI? Well, come on, you got to talk loud. No. So you're kind of right. So if you dilate the annulus, it pulls the valve apart, and you get AI. If you dilate the sinotubular junction, it pulls the post apart, and you get AI. If you dilate the sinuses, all you get is a big aneurysm, it ruptures, and you die. And so that's important to understand, because people think big sinuses lead to AI. Big sinuses don't lead to AI, but a big annulus and big sinotubular junction does. And then the cusp. You can perforate your cusp, you can prolapse your cusp, and you get retracted cusp. And retracted are things like rheumatic that comes back. Prolapse is often bicuspid valves, and perforation is usually endocarditis. There's a whole thing based on Carpentier's mitral that we use for the aortic valve too. When it's the root, if it's just a sinotubular junction that's big, you can just bring a graft down, it pulls it back in, it goes away. If it's the whole root itself, we actually bring a graft over it, and so the valve inside of it. This is kind of what it looks like. Sinus Valsalva is important. It goes all the way back to Leonardo da Vinci's showing how the vortexes would help your leaflets. So with sinus Valsalva, you get these vortexes behind the leaflets. They do two things. One is they keep the leaflets from banging against the wall and closing off coronaries. And number two, towards the end of systole, those vortexes start to close the leaflets. So by the time the pressure changes, those leaflets are already half closed. They don't go from completely open to completely closed. But if you look at a surgical valve, they go from completely open to completely closed. They don't work like a normal valve because we've disrupted things. Also true if you put a tube graft in there rather than a sinus Valsalva. In fact, in your valve, when does your valve open? What makes your valve open? What's the first time that there's a hole in the valve?
Just before system.
Well, what makes it open?
Pressure. So it's
Huh?
Pulling.
It's pulling. That's the key. It's not the pressure. Everybody thinks it's the pressure. It actually opens before the pressure is higher in the ventricle than the aortic. Because as the heart pulls and twists, it actually starts to pull the valve open and increase the annular size. Now this is not a long time that it's open because you get leak. And then it ejects, and when does it close?
when the heart untwists.
So do you have to have a higher pressure in the aorta than the ventricle to close? No. Actually, your ventricular pressure falls below aortic pressure before the valve closes, and the continued kinetic energy keeps it moving forward, and then it closes. If you put in a surgical valve, though, it opens when the pressure is higher in the ventricle, and it closes when the pressure is higher in the aorta, so that you're actually seeing a higher pressure more of the time inside the ventricle if you have an artificial valve in there. So your valve does kind of open close in a funny way. When these things prolapse, we have a lot of ways of fixing them. And mainly it's just a matter of reefing up the edges. I don't have a picture that really shows it, but what happens is it just prolapses in there. Dissections, you guys see type A dissections, they come in with AI. Why do they have AI? Why does the dissection, a acute type A dissection, get AI? Rip a hole in the valve? Magic? Why does acute type A get AI?
The support system was
The support system. The dissection goes down, the post pulls away, and it prolapses. So how do you fix that?
you support it.
You pull it back up. So we literally just take a little pledgeted suture and we go through the top of the post to the outside and pull up to where it's supposed to be. Very, very tricky. I trained years to do that. And then that fixes most of the valves, and you can leave it in. Now, that doesn't count if they already have a root aneurysm, or if they had aortic valve disease to begin with. But most of the type A's that have normal aortas, we can preserve the valve. In the older days, people would see AI and they just replace the valve. Well, now you've got, a big operation. You're adding extra things to it. And this is how prolapse works. It just the edge falls down, and what you have to do is pull that edge back up. And there's all sorts of fancy measurements about how long the free edge should be compared to the margin of the valve. The easiest thing to do is I just take some little tiny sutures and I suture these together until there's a bunch left over, and then I suture that and then cut the sutures out. Just kind of plicate the valve until you get everything in the middle, and then whatever leaflet has the extra stuff, just reef that up and then cut the little tiny sutures out that you sewed it together with. And this is what it looks like. You have this long valve like this, and you basically just take a piece out. This was a quadricusp valve. You can actually take one out and make it a tricuspid valve. Leaflet extension, I wouldn't recommend that. Magny Coop started those in London. Magny was kind of a crazy guy, and the first one he did, he didn't tell anybody he was going to do it. And the cardiologist, he thought he was going to give the guy a mechanical valve, and the cardiologist went and listened, couldn't hear it. He said, "Magny, I don't hear a valve." And he goes, "I fixed it." 2 days later, it broke down, and he had to put a real valve in it. So I'm going to stop because we're almost at the end of the hour. We got 2 minutes. I'm happy to answer any questions that you have.
What kind of AI would you envision will work well with transcatheter valves? Because endocarditis is probably out, right?
Well, endocarditis is out. So if you look at AI in aortic transcatheter valve, the partner people showed that even mild AI had an effect on your mortality. Any AI increased your mortality. Now, up till recently in the core valve, we saw no signal with mortality with anything but severe. But I'm always careful to tell people that I don't think that AI is a good thing. I just don't think we have enough numbers. We're going to present data soon that shows, just like partner, AI is bad for you and kills you. And so what you really want to get down to is no AI. Now, the interesting thing is the newer generations of valves are getting down towards no AI. So the Lotus valve that has a skirt on it, the AI beyond mild at 1 year is 0, and there's only about 20% with mild, 80% of them have no AI. S3, real low because it has a skirt on it. Evolute R, real low, but a little bit higher, it's 3.4 at a month. But once we add, when we get to Evolute R 2.0, I'm going to put a skirt on that one, and then it'll go down. And so I think in the next couple of years, we'll be seeing basically something very similar to surgical valves. In the mitral space, which I'm also very interested in, there's a couple that I'm working on bringing here right now. It's going to be a bigger problem because the physiology of the mitral valve and the pressures are much greater. And so paravalvular leak in the mitral space is tolerated much less well in the aortic space. We know that in the surgical literature. You get a surgical paravalvular leak right after surgery, it's there, it's a technical issue, it's not too bad, it doesn't get worse. If it's mild, it'll be mild 5 years from now, and you'll tolerate it okay. Mitral, it's mild for a while, then pretty soon it's moderate because there's just a lot more pull there, and they just don't tolerate it anywhere near as well. But the key is you want it down to, and particularly as we move into younger, patient groups, we want it down to pretty much 0. Look like a surgical valve. In fact, I think the data is slowly building that once we get to that, the only thing that's going to derail TAVR is if the durability turns out not to be very good. And we have valves that have been up to into 7 to 8 years now, and we don't see any signal. But in the surgical world, we know that we usually don't see a signal for structural valve deterioration until about 7 years after you put it in. And that's for people in the US and Canada that have an average age of 66 to 70. The older you are when I put a tissue valve in, the slower it degenerates. What's the average age in the US randomized trials? 83. Are we going to get an answer about durability? No. They're so old, it's going to take them forever to go away, and they're all going to be dead. We're not going to have enough. So from the core valve in the partner trial, unless they fail early, which we see no signal for, we're not going to know. There's not going to be enough later on to figure it out. So until we get partner 2A and SURTAVI or some bit longer term TBT data in younger people, we're not going to have a durability answer. And when we get that answer, we've all learned from the cardiologist, we're going to say, we don't use that valve anymore, it's the old valve. You're getting the new valve, but I'm sure it's going to do better. Yes?
Are you doing transapical TAVRs here?
Well, we've done transapical mitral valve and valve. I don't do transapical TAVR because I just do a direct aortic. I like direct aortic more than transapical. I debate Tommy Walter from Germany every year on this. Tommy was one of the fathers of transapical. Tommy says transapical is just as good as transfemoral, and there's never been any data to show that transfemoral is better than transapical. And I keep telling Tommy, Tommy, there's no data that shows jumping out of an airplane with a parachute's better either. But there's certain things that are just okay to assume. When we bring in the mitral valve program, all the current mitral valves are transapable. Now, I'm developing a transseptal going through the right atrium, through the septum, and then eventually we want to go up to your leg. But right now the systems are fairly bulky. And I hope within 6 months we have one of those.
So other than bad peripheral arterial disease, is there any other indication for transapical TAVR?
We have really bad arch disease that you're worried about causing a stroke. So you have this big atheroma hanging down. We had one guy we echoed, and the peripheral wasn't so bad, but Steve Little echoed the guy, and you could just see this thing in his arch. I didn't really want to pass the valve past that, so we just did it direct aortic.
Most of the data is for the transfemoral TAVRs, correct?
Well, there's a lot of transapical data, and there's, if you look at the early partner trial, which is where it really started, in the early trial, the transfemoral was much better than transapical. But then when you moved to continued access after the trial closed, the transapical data got a lot better because people learned how to do it. And I just reviewed a paper from a really big institution who was very proud because they want to point out that their transapical data was just as good as their transfemoral data, with the caveat that for the first 33, their mortality was through the roof. And then after 33, they got really good. And they were claiming that just shows that once you get through the learning curve, the problem is twofold. Number one, they got through their learning curve in the partner trial when 40% of the people needed a transapical. Right now here, 90% of ours are done transfemoral. So it takes you a long time to get through the learning curve. And number two, wasn't they learned how to do transapical, they finally figured out which people not to do this on. It's a patient selection issue. And so, transapical is not going to go away. It's going to be used in the transmitral valves, the transcatheter mitral space for a while, but even that will eventually go transeptal. I mean, if you don't have to poke a hole in the ventricle, and Bill Farron from Stanford has shown that if you have a low EF to begin with, and you have a transapical versus transfemoral, the transfemoral will get more EF recovery than the transapical. Now, this paper claimed the opposite, but I pointed out that you happen to be at odds with the whole rest, plus you didn't tell me what your EF, you just gave me an EF to begin with and EF at the end, you didn't tell me how many people had EF below 50 to begin with. But if you already have a normal EF, I don't expect you to get better no matter how we do it. So it was a kind of a crummy paper.
Dr. Reardon, these patients, the ones who don't augment their stroke volume, how many what are we doing?
So we
don't
have-
see that many in the echo lab.
Well, we right now have a study called the low flow, low gradient study that'll allow, so if you come in and your gradient is, your mean grade's above 25 but less than 40, and you have an EF less than 50, and you don't augment, we can put you in that study. Or if you have a normal EF and you don't augment, and your stroke volume index is less than 35, I can put you in that study.
Okay.
And that data is going to all be presented at the ACC this year. Or no, maybe it's going to be TCT that's going on in San Francisco. Either TCT in San Francisco or ACC, one of the two. And what we found is that the low stroke, low volume, the low flow, low volumes actually did pretty well. The problem for me as a surgeon, is that these people all have really high surgical mortalities. And the interesting thing about TAVR is it tends to decrease that early mortality. That's going to be the interesting thing about the transcatheter mitrals. But if you remember Mike Acker's paper from the New England Journal, repair versus replacement for functional MR. If you got a repair and it held up, you did really well, but 1/3 of them failed by the end of the year. Actually, they probably failed by the next day. Nobody took an echo. They probably weren't really repaired. And they did it, well, they look good in the OR because you're doing a TE. And the TE in the OR is useless. But if you did a replacement, you didn't get mitral regurgitation. The problem was the upfront risk of having a replacement was much higher than having a repair. So now if I can do a complete replacement, but without the risk by being non-invasive, then the question is, will it help FMR? And the whole key around the mitral space is that for people that have degenerative disease, we can fix that really well as surgeons. There's only a few people that we don't want to operate on. FMR is a huge patient population. The problem is nobody's ever shown that we make you live longer by fixing your valve or really live better. And part of that is because our repairs, even in the hands of experts, fail. Because when Mike Acker's work was presented, one of my mitral valve buddies from New York stood up and said, well, these guys are mitral valve repair experts, but they weren't experts at repairing functional MR. And I finally had to say, David, pretty soon it's just going to be you and two other guys that can do this, because if so, there's no trial we're going to design to do this. These guys were the experts doing it, whether you think they're FMR experts or not. Okay, well, thank you very much.
Thank you.
Thank you, sir.